Hi, I'm Mike Duggan. I've been teaching restorative dentistry for over 32 years now and to over 6,000 dentists. This video shows how I do it. Real-time, mannequin-based, hands-on, point of view, and patient real. If you are a pre-dental student, an aspiring teacher, an international dentist, join me at Duggan Oral Design, dugganoraldesign.com.
So how was yesterday? It's a learning experience, as I said. Doesn't matter so much how well you do, it's a matter of how well you learn to do better. And several people did really well, and several people didn't do so well. And so that's the pretty big range in between. But the people that didn't do so well, for example, one of the common things was lots of ski jumps. Ski jumps. So we certainly spent a lot of time talking about ski jumps. And so in order not to hand in a prep with a ski jump, what steps do you have to go through? Okay, if you want to show a prep, if you want to hand in a prep for grading that doesn't have a ski jump, how do you do that? How do you prevent handing in a prep for grading that has a ski jump? Well, you start by looking down the wall, and if you see a heavy chamfer, if it's more than half a millimeter, you're suspicious. And then you take the ball burnisher, slide it down. If it stops, it's a ski jump, and you look from the side horizontally along the wall, and if you see the lip coming up like that, then it's right there. And then, of course, in order to fix it, you take the end of the burr, put it back to the surface where it should have been in the first place, and then drop gingivally. If you have to go subgingival, you have to go subgingival, but you've got to get rid of it. You can't hand it in that way. Okay, so 3 people handed in preps that failed because of ski jumps. Actually, there were 4 people that failed at least 1, if not 2 or 3 preps because of ski jumps. Okay, so that only means that you aren't actually looking to see if you have a ski jump. Okay. Most of you are getting to the point where you can fix them, and I've shown you how to fix them, and most of you can't fix them, but you can't fix what you can't see. Okay? And of course, you can see it. Can I give you a little extra sound? No, sorry about that. I thought it was extra sound coming from outside. So the only reason you can't see something, let's see, what is the main reason why you don't see something? Yeah, or you don't look for it. If there's something that you're wanting to check to see if you have it, then you look for it. And you figure out a way to look so that you can see if it's there or not. And then you do something. If you have to make a change, you make a change. See, that's what the worksheets are all about. And, it takes a while to really spend some time with those worksheets and develop them. And if you do that, developing that worksheet, if you modify it, expand it, enlarge it, break it down into smaller steps, organize it in a way that's really helpful for you, have the order in a way that's easy to remember, then by the time you've done all that, it's into your head. And you can look at any prep, whether you did it or somebody else did it, you can look at it and go, okay, I'm going to check over here for this, I'm going to check over here for this, I'm going to check over here for that. Okay? And you've got to very deliberately and intentionally, with great enthusiasm, look for your errors. And if you break it down into small steps, if you break it down to look at this error over here, look for this error over here, look very specifically in very specific places for very specific things, then you've boosted your chance of seeing the error tremendously, probably by 10 times. And of course, once you see the error, then you have a choice. Do you leave it or do you fix it? And of course, that's not much of a choice, is it? See, if you have an error that you know you're going to fail, you don't have much choice. You got to try to fix it. And if you know you have a ski jump and you're afraid to fix it, then you probably are afraid because you never fixed a ski jump before. So that's why I show people all the time how easy it is to fix the ski jumps. As long as you're looking along the wall horizontally, you see where the end of the burr is, and then you can drop that margin gingerly. And of course, if you can do that, then you could have avoided the ski jump in the first place. So those are things that you still need to be working on. So don't think that this course is over today. Okay, it's not. It keeps on going. So don't think that you're through working in the workbook. You're not. There's lots to learn from that workbook. You know, even the visualization exercises. You know, a few people that were doing pretty well on them didn't get to that last set. And that's where it really gets fun. Okay? But really put some effort into that. Again, 3D visualization is one of the reasons why people don't see their errors. They don't have this concept of 3 dimensions as well. Okay? And you know, there's a combination of things that lead to people not seeing their errors, but that might be one of them. So the more you can develop that, you know, profound sense of 3D, and the more you can visualize things, and you know, you can picture, okay, if there's a ski jump on the distal, if I look this way, that's what it's going to look like, and that's what I need to look for. So all that kind of stuff is what makes the difference between doing preps that fail and doing preps that pass. Okay. So let's definitely keep in mind that, you know, when you leave here at the end of the day, you know, you're going to take a lot of this course with you and keep working on it. Okay? Maybe during the course, you know, the intensity of the course and, you know, whatever else you had to do in terms of getting home and not having enough time there and you know, this kind of thing. There are all kinds of different situations that happen during the course. But, you know, allow some time every day to work on this material. And especially the visualization part of it, and as well the, you know, writing out for yourself very, very deliberately. Now that it's much more fresh in your mind after yesterday, write out for yourself very, very deliberately, you know, what are all the things you have to look for. Okay? Again, that's what makes the difference. If you find an error, if you make an error, it's not a big problem. If you find an error and then know what to do to fix it and actually do the fix, that's what makes the difference between passing and failing. Okay? So again, you know, today we'll probably take several of the preps that you did yesterday that failed, and we'll fix them. And that's kind of a very educational experience. You know, when you know that, okay, I had this prep that failed, and now I just made it pass. And then you ask yourself, well, why didn't I do that yesterday? It's a really important question, isn't it? Okay? I could have made it pass, and yet I didn't. I chose to hand it in the way it was. Maybe it's because you didn't see something. Maybe it's because you were afraid that you couldn't fix it. But, you know, the fear part of it is something that you can easily overcome. Just finish every prep that you start. Okay? Like I said from the beginning. You know, a couple people were getting very good at going gingerly on a class 2, and a couple people just haven't gotten that good yet because they haven't done it enough. Okay, so you should have gone gingerly that 7 steps. You should have done that at least 100 times since the beginning of the course. Okay, again, every class 2 prep that you have done, you can go gingerly 5 or 6 more times just for the practice. So do that, and then you start to get confident in it. If you get confident that you can make a change, then you don't have to be afraid to make that change. Then you will make the change, and then oftentimes that makes a difference between passing and failing. Okay. So there's a bunch of things that this course will lead you to continue with and to keep working on. And you know, when you get into a school program, then you know, make sure that you are doing everything very deliberately, very carefully, and you know, multiple times as much as you can. But again, you will have, as you go into a school program, a very profound sense of what you need to see and how to make sure you see it, and how important it is to make a change. And you know, what's the difference between passing prep and failing prep? So make sure you take that with you, and that will guide you very well over the years through dental school and then for a considerable career after that. Okay, any questions about how yesterday went, or anything else for that matter? Everything's pretty clear in your head? Okay. All right, so, you know, like I said, you guys did okay. You know, some people are really suffering and struggling, and some people are doing quite well. And then, so you kind of, as a group, you came out, you know, kind of average as far as the average group is concerned. But again, it's all a matter of, you know, what you're getting individually. When you look at your grade sheets and you see the errors that are there. And of course, at some point, you'll have access to the video. If you didn't videotape my comment on yours directly off your screen, you'll have access to the video that you can look at. And then, you know, watch that and then keep processing, okay, why didn't I see that? And if it takes me like, you know, a millisecond to find a couple of failing errors, you have to very deliberately ask yourself, okay, why didn't I see those? They're right there to be seen. You don't even have to work too hard to see them. And if you have errors that are seen that easily, then you ask yourself, oh, how come I didn't see those? Okay, and so there is a point where you really have to be very deliberate about it and very rational about it. Say, okay, these are the things I have to look for. These are the things I have to see. And then make sure you do them and practice doing them over and over and over. Every prep that you do, practice looking for specific errors. Then you get really good at it. Okay? All right. So today we're going to move on and utilize a lot of the skills that we've been working on so far and sort of combine them together in a different kind of prep. And that'll be kind of fun. So we won't be having any homework on the Typhonauts tonight. So that'll be kind of nice too. Kind of refreshing in a sense. But this is a pretty casual day, but it has to do with a couple of preps that are important. So basically we talked last week about the difference between extracoronal retention for a crown and intracoronal retention for a crown. And I talked about my patient Mary that had all the amalgams removed from her mouth and replaced with composites, and she was in severe pain for months. And then she got out of pain when I removed the composites, immediately out of pain, which was kind of cool. She wanted to have a very long-term restoration, so I did gold onlays for her. I told you that you can look at pictures of those onlays in her mouth on the onlay and gold crown chapter on the website. I don't know if anybody's done that yet, but it would be cool to do it. And again, don't forget, you still have access to the Udemy course. And now, if you haven't signed into it yet and used the coupon to avoid spending the money, do that soon, and then you have access for as long as you want. If you wait too long and the coupon's no good, then you'll actually have to pay some money. So it'd be nice to save some money. Anyway, so utilize some of these resources that are available to you. But again, you know, look at that website, spend some time on that. There's a lot of stuff there. And send me an email. Let me know what you think. Let me know what your observations have been in the practice where you work, if you're working at a practice. Because, you know, we're trying to make sure that we get information out to the general public about how dentistry really is. And so, and you need to get as much of a sense as to what the public understands and how to educate them as you can before you go into practice as well. And of course, you can learn how to do that really well by working with patients in school where you have some time to do that. So make sure you pay attention to when you have patients in school, how you communicate to them, how you teach them, how you educate them. And refer them all to look at the website, web-dds.org. You know, don't miss a chance to do that. Okay, so anyway, extracoronal, intracoronal. We've certainly spent lots of time with extracoronal, both full bowl crowns and partial veneer crowns like the 3/4 crown. So the intracoronal retention is what I did for Mary. So I took out her composites, and there's not much left of the facial lingual cusps. In a little bit, I'll show you a cast of her. So you'll see the first two onlays that I did for her on a couple of upper premolars. So you'll see there's not much left of the facial lingual cusp. So if you thought, okay, I'm taking these out, she wants something that's permanent, I'm going to do a crown. And we've talked about PFMs and full ceramics and so forth. And if you did a crown, what would be left of the cusps? So when you look at her cast and look at a couple other casts from patients where I did onlays, gold onlays. Look at the size of the facial lingual cusp and realize, okay, now if I'm going to reduce this much axially, those cusps are virtually going to disappear. So that's what we talked about before. It's ironic that you're trying to do a crown prep to protect those cusps, and then in order to retain the crown, you're cutting the cusps away. That doesn't make sense somehow. So there are some options, and so the gold onlay is one option, and so you can see the pictures of Mary and see what's going on there. And the other option is a porcelain onlay. Now, as you know, a porcelain onlay, you know a little bit about porcelain. You know that the bulk of the material, the bulk of the porcelain at the margins should be as close to 90 degrees as possible. So we're not going to have any bevels or anything like that at the margins. So we have a nice bulk at the margins. You know, we're reducing, quite a bit more, and we don't want something that is going to provide any kind of mechanical stress. We don't want a prep that's going to provide any kind of mechanical stress to the ceramic. So we make sure that the walls are not too parallel. And if we have 10 or 12 degrees for a gold onlay, that'll be quite retentive. But typically for a porcelain onlay, we're going to do something that's a little bit more divergent. Okay. So and I'll tell you a little bit about the situation in my mouth. Two different situations. I referred to them, but I had two porcelain onlays done in my mouth. And again, you might ask yourself, well, why did I get, knowing me as well as you do, and knowing my belief in gold crowns, and why did I get porcelain onlays done in my mouth? And the answer is, I was offered to have them done for free, and it was important to me at that time to save some money, so I decided to go for it. But on the other hand, I learned a lot about porcelain onlays from my own personal experience, which I'll share with you as we go along. But remember that with porcelain onlays, it's not mechanically retained. We don't want it mechanically retained. There's nothing that's going to put that kind of stress on the restoration. And so it has to be adhesively bonded, and the adhesive technology is something that's fairly sophisticated, and it can be very effective if it's used well, and if the full technology, the range of technology that we have is actually utilized in the patient, and it's utilized well. And as I said, I had a porcelain onlay fall off in a week. And then he put it back on, and because of it was a CAD-CAM onlay, it had a wide open margin. So I'll talk to you about that. Not because it was a CAD-CAM, it had a wide open margin, but he was in a hurry, perhaps, and allowed that margin to be open, and that led to some problems later on. So we'll talk about that and what I chose to do to replace that. Okay, so intracorneal retention. We'll talk about gold onlays first. And the ironic thing is that you'll go to dental school, and for generations, dental students have done gold onlays in the lab in order to learn the basic skills and techniques and principles behind that kind of retention. And of course, again, the beauty of it is that we're doing a restoration for a tooth that does not involve cutting away much more of the tooth at all. It's the least amount of additional material you can cut from the tooth and restore it. And it's the most long-lasting restoration that we do as far as indirect restorations, and it's kindest to the opposing teeth. So that's kind of cool. So you might want to think, okay, if that's that cool, then why don't a lot of dentists do it? Okay, so you'll figure that out as you go into dental school. A lot of times dentists don't do it because they think it's really tricky. It's a tricky prep. So think about it. There's two boxes instead of two grooves. Okay, well, two grooves. Some of you got the groove thing down, bang, you got it. So the boxes, it's just the same kind of thing. It's just a bigger retentive feature. We have 4 flares. We're flaring each side of the boxes because the lingual surface is not prepped. So 3/4 crown, we didn't prep the facial surface, and prepped with the chamfer and taper axe reduction on the lingual surface. For the onlay, we don't prep either the facial or the lingual. So both of those margins are up high. So all those margins can be burnished. And with 3/4 crown, we flared the facials out into the embrasure so we could burnish those. And now we have 4 flares on the onlay, so we can burnish all those. So the only margins on the onlay that you can't burnish are the gingival margins. So we make sure we bevel them well, cast them well, and so forth. And so that's one of the reasons why those restorations are so phenomenally long-lasting. It's because so many of the margins are basically the best margins that we can actually do in dentistry, if one takes the care to do them that well. You know, you might ask yourself, okay, if your wife or kid's sister or whatever, you know, needs a crown, you know, how would you advise them? Okay, what would you want to do for them? And, you know, if you're knowledgeable enough about what the choices are, you know, I would like to think that you would all make a wise choice, you know, with the patient in mind, since they're so close to you. But then again, there should never be a difference between that decision that you make about a loved one and the decision any dentist makes about any patient. Okay, there should be no difference in the quality of that decision. Just to let you know, in my humble opinion. All right, so why are we doing an onlay on a tooth? Well, it's missing a lot of tooth structure. So there's probably an old restoration there like Mary. There's an old composite restoration, so I took those out. Not much left of the facial lingual cusp, but lots of tooth structure missing. So there's boxes there already. So that sounds kind of cool. So there's boxes there already. So the occlusal reduction, you don't have a whole lot of occlusal reduction to do, as I've talked about before, because a lot of the occlusal surface is missing already once we remove the original composite. You know, probably the B incline is totally gone anyway, and probably part of the C incline and so forth. So there's a lot of occlusal surface missing. So doing the occlusal reduction, it's way easier than what we've been doing. All right, some of you are having a little bit of trouble getting the vertical angles right, getting the ridges in the right direction. Well, you know, it's pretty easy to get the ridge in the right direction if you don't have to make it. Okay, it's already gone. So you're not going to do a plane there or anything like that. So the occlusal reduction is pretty easy. And so the boxes there's boxes there already, so you don't have to make boxes. They're already there. And the patient, they're already there. You have to make sure the boxes work, that they actually provide some retention, but that generally doesn't take a whole lot of effort to make that happen. So you got a patient that you don't have to do much occlusal reduction. The boxes for retention are already there, and make them work. Do 4 flares, bevel and offset, and you're done. Well, it turns out that's pretty simple to do. Now, when we do it on a typodont, as you will do in school, then you have to make the boxes from scratch. You have to you do all the occlusal reduction, just like you've done before. And then you have to figure out where the boxes should be, how big they have to be, how small you can make them, and so forth. And it turns out that you can make boxes pretty small that'll actually retain the gold on the occlusal surface. You can make the boxes so small that in reality, if in the core of the tooth you could take care of what's missing or decayed with boxes that small, then there's so much of the original tooth structure left, none of the cusp will have been weakened by those boxes. So you don't need to do a crown. So that's the ironic thing. In dental school, when you're doing a conservative academic style gold onlay, MOD gold onlay, if you're being conservative about it, as conservative as they want you to be, then you look at the prep and you realize, okay, nobody's going to do a prep like that on a patient because all the cusps are strong. We don't need to cover the occlusal surface. There's no cusps that need protection. Okay? So we don't need a crown. If you have boxes there already that are that small, you can just do an MOD amalgam or an MOD composite or MOD inlay. It doesn't require an onlay, doesn't require cuspal coverage. So that's where students get in trouble in dental school. They do these preps and they're tricky. And we're going to do one today, and it's kind of tricky. You've got a lot of the skills already for doing it. But, you know, it's pretty small, requires a fair amount of precision and so forth. So most students in dental school can't do it well. It requires a little bit too much skill. So they say, okay, well, when I get out of school, I'm certainly not going to do an onlay on a patient. That's the last thing in the world I want to do. Okay? And again, it's one of those childish reactions. But it's also the rubber dam thing we talked about before. But it's also the fact that, they think that this preparation has to be done that conservatively. And if it has to be done that conservatively, it requires your utmost skill. And in a patient, it's never that conservative. Like I said, if it were possible to make it that conservative on a patient, you wouldn't be doing a crown. So in a patient, the boxes are going to be quite large because the cusps are going to be weakened. So then these boxes, they're big. They're already there, and they're big. You just have to modify them a little bit and then move on. So what I learned from Mary, and again, just to make this point crystal clear, your best teachers in dental school are your patients. Okay, you learn more from them than from anybody else. So I learned a tremendous amount from Mary, I not just getting to know her and talking about the choices that she'd made and stuff like that, but I certainly learned how easy it is to do onlay preparations in a patient. I didn't know that until I had her as a patient. I did my first onlay preparations on her, and I did 2 onlay preps on 2 premolars, side to side. I did 1 provisional that covered both of them. It was easy. And back then, you got points as a student. You got points for how many crowns you did, and so I got 10 points for each crown, so I got 20 points. Cool. And it was very easy to do. It didn't take all that long, and it was a delightful experience. That's what taught me that, when I get out of school, when I have a patient that needs a crown and there's a couple of boxes there, I can throw an onlay prep together and it's easy, okay? It's just not that much to do. It's way easier than you think it is when you're in a dental school doing it on a typodont, if you haven't had the experience of doing it on a patient. So if you can find in dental school the opportunity to do some onlays on a patient, that's hugely valuable. Okay. Now, ideally you do some gold onlays because they have some huge advantages. And you might be able to educate your patient to the point where they actually understand that. Refer them to the chapter in my website to read. But maybe you'll do a porcelain onlay. Okay. And so we'll talk about both of those today and how they differ and so forth and what the advantages and disadvantages are of those. But we'll talk about both preps today. I'll demonstrate a gold onlay and I'll do it on a typodont. So it's going to be conservative boxes, which means it's meaningless. This is basically an academic style exercise to develop some skills. And then later on I'll take my gold onlay prep and modify it so it would be suitable for porcelain. So get an idea about the differences there. Okay, but and if you wanted to practice today, if you have a tooth, in fact we're going to be working on number 3 today. Let's say you have a number 3 that you've already done some class 2s on, and the boxes are really big. I don't mind at all if you use that to do your onlay prep on. Because that simulates pretty well what the patient would be. I wish I had had a company make for me a long time ago. I could have done this, I just never got around to it. Make some teeth that have, large MOD preps on them already. Much bigger than ideal. And then use those to practice doing onlays. That would take the student to the point where they're understanding that actually when you've got all this tooth structure missing from the beginning, doing the onlay prep's pretty straightforward, pretty easy compared to what it is on a typodont where you're trying to make it from the beginning and keep it conservative. If you really want to get the irony of this, so if you're doing an upper premolar prep, let's say you have a choice, let's say you're having to choose between a gold onlay and a PFM, okay, for example. In order to do the PFM, of course you have a lot more reduction to do. You have to put that facial margin really as far as subgingival as you can, and everybody has trouble doing that as well as they should. Once you've done that, you have to take an impression, and that's much more difficult. That's why people are afraid to go far enough subgingival. They're afraid they won't get a good impression, for those who care whether they get a good impression. So you got more work to do the impression. Then, of course, if it's an older patient, criteria taken into account. That sounds rather difficult, as opposed to a gold onlay. Okay, gold onlay. Okay, when we're doing the prep, we don't reduce facial lingual surfaces at all. We don't have a facial margin to be subgingival. It's way up here on the incisal edge, hopefully. A couple of you yesterday didn't quite get how important it is to keep it up on the incisal edge. Most did. But, so the margin's up here. Didn't take too much time to do the occlusal reduction. Didn't have to reduce facial and lingual. The margins are supragingival. They might be subgingival in the proximal area, but that little piece of cord here and a little piece of cord here, you get a good impression very easily. Shade selection is very easy. There's only one shade. Okay, the shade guide for gold crowns is really nice. It's just a piece of gold. Okay, it looks like gold, okay, we'll do that. And of course, you don't have to deal with the opacity and so forth. So, and yeah, the aesthetic issue is just missing because you've done the prep so that nobody's going to see the gold. When you're doing a restoration that everybody sees, like a ceramic restoration, then that whole aesthetic, cosmetic, all those decisions come into play. So in reality, you know, if you know how to do a gold onlay and you're doing it on a tooth that has these boxes already, which you will, then doing the prep is pretty easy, and all those other things don't have to be done. So in reality, the amount of time that it takes you as a dentist to do a gold onlay prep and seed the crown and, you know, this kind of thing, give directions to the lab and all that kind of stuff, is way less time. It's going to require much less of your time than it is to do a PFM or a full ceramic. So that's kind of ironic in the sense that if it takes you less time to do that, what's the consequences? You know, if you have two preps and you choose to do this one, the gold onlay, and it saves you a lot of time compared to what it would be if you did this one, what's the consequence of that? If you save time, you make more money. All right? And so if a dentist is only doing dentistry to make more money, and he really doesn't care so much about the patient's welfare, if he only is concerned about making more money, then that dentist would only do gold onlays. That's what's ironic. But when you learn in school how tricky they are, because you're only doing them on a typodont and you never did it on a patient, you don't get how easy it is to do it on a patient. Okay? So again, when you're in school, make sure you take the opportunity as often as you can to do cases like that, and then make that discovery that Mary gave me, and then have the same discovery yourself, and then your practice might be a lot more flexible and varied than you might think, and you'll be attracting people into your practice. They're deliberately coming because they really want to get the highest quality dentistry possible. Okay, so we'll talk about how to do a gold onlay. Now again, in a clinical situation, now I'll show you some casts, by the way, of different situations, but you know, a clinical situation, we've probably got boxes already that are, you know, really big. And an isthmus that's really big from some prior restoration. So there's not much left of these cusps. That's why we're doing the crown. There's not much left of those cusps. But all this missing tooth structure we use for retention. Okay, so this, we might have a big box like this on the tooth already, a little bit undercut facial angle, whether it's amalgam or composite. So all we're going to have to do is take this box and make it diverge a little bit facial lingually. So lean the lingual out a little bit, facial out a little bit, get about a 10 to 12 degree divergence between the two walls facially and lingually. And so we've just modified these walls of these big boxes a little bit, leaning them out facial lingually. The axial wall, we can ignore. Isn't that cool? We can totally ignore it. Probably it's way in deep. So we're not going to put gold all the way that far in. So we don't care whether it's undercut or draws or whatever. We could base that area back in and put an axial wall right here on our prep, or we could just take an impression of it the way it is and have the lab block it out. It's essentially the same thing. The lab blocks out that area. They're going to make a gold crown. The gold crown is going to have an axial wall about right here. It's the facial angle walls that are important. Okay. We need to make sure there's enough height. At least 3 millimeters. Like typical for crowns, you want to have at least 3 millimeters wall height and a reasonable taper. And so if the walls are tall enough and they're drawing without too much divergence, we've got the retention that we need, and we don't need to deal with that axial wall at all. So wait a minute. Do the occlusal reduction. Not much of an A plane, no B plane, not much of a C plane. The boxes are already there, make them draw facial lingual, ignore the axial walls. Doesn't this sound kind of easy? Sounds too easy, doesn't it? Okay, well, when you have the experience on a patient, then you might get the idea that, well, actually, it is pretty easy. Okay, so, typically we're not going to do that like this today, but again, clinically, that's what it is. So we're going to look at some cases. We're going to look at some casts and get an idea. I'll pass them around, and then you can sort of see 3 different onlay cases. One of them is Mary, the two premolars next to each other, that's Mary. Just introducing it. And a couple other cases as well. So I'll pass those around so you get an idea. But first, there are a couple other things I want to show you. And so we talked before about a case that was a full crown case, and I over tapered the distal wall of the prep, as a couple of you did yesterday. I had a good reason to do it. Okay, we talked before about why I over tapered the distal wall of the prep. Remember why that was? Yeah, the adjacent tooth is leaning over mesially, and it's doing that because the original first molar here had distal decay. And so that allowed the tooth to move into that decayed space, and then we've got to deal with that when we do the crown prep. So over tapered the distal and then put a groove on the facial. So you see the little groove on the facial. 170L burr, just like you've been making. Anyway, so I'll pass that around. This one is particularly interesting. This is a premolar partial veneer crown prep. The patient came in, actually it was one of my students at the time. She was a Brazilian dentist, so she knew about gold crowns and partial veneer gold crowns and so forth. She had had her lingual cusp cleave off, just broke off of that premolar, right down maybe a millimeter subgingival. But that whole lingual functional cusp was just gone. So I said, okay, we'll take care of it. And so she came into my office, and we did this prep. And so in order to get some wall height, of course, there's no cusp there. So in order to get some wall height, I had to rebuild the lingual cusp. I did that with amalgam. I put 2 pins in the corners, build it up with amalgam, had a nice strong cusp. And then she wanted to have something that was aesthetic. So conversationally, if you look at this cast, conversationally, you can't see any preparation. Okay? So if you're looking in this direction. But if you look down here, you realize it's almost a full gold crown. Okay? But the mesial-buccal area, it was possible to preserve the mesial-buccal area. Now, I also came around, so a 3/4 crown would make sense. But for a 3/4 crown, the mesial and distal grooves, one of them they would both have to be in the amalgam. They both have to rely on the amalgam to retain the crown. So remember I was talking about that case where the full crown was full of amalgam and the guy didn't use pins to retain it and so forth, and the whole thing fell off. Didn't want that to happen, but I had pin retained amalgam, so I was confident about that. So the mesial groove, part of the groove, the lingual wall of the groove was in amalgam, but I took the distal groove around the corner under the facial surface. Okay? So effectively it's a 7/8 crown. So I've prepped half of the facial surface, almost half of the facial surface. But still, conversationally, you can't see that there's a crown there. So she was very happy in that conversationally nobody knew that she had a crown there, and yet it provided all the advantages of the gold. So I'll pass this around as well. So again, those are things that, if you understand the principles behind partial veneer crowns, and you have a patient come in that has a certain issue with the tooth, then you can figure out what to do. Okay? If you're willing to do that. Okay? Probably the vast majority of dentists these days would just say, okay, you need to have a crown. They whip out the CAD/CAM machine and do everything, but what are you going to do about that lingual cusp? Okay? Go really deep subgingivally, try to find some tooth to hold on to. And then really deep subgingivally, how do you actually protect the tooth from contamination when you're cementing it adhesively? Pretty tricky stuff. All right, and then, so pass those around. Now, this is nothing that we've talked about in this course so far, but I just thought I'd talk to you a little bit about what you might run into. Again, you have a dental practice, people walk through your door all the time, and sometimes some very surprising things come in. So here's one person, and so if you look at these casts, I'll pass them around in both directions. If you look at the cast, there's no teeth apparent, are there? Okay, they look like edentulous ridges. And if you look at the cast, there's an outline in each cast of the root, where it's been polished off right to the gingival level. And so the patient, this was his bite, like this. So the only time you've probably seen anything quite like this would be, you know, an older person that has full dentures and didn't put the dentures in that morning. You know, so their lips are all compressed. So that's the way he looked. And any idea how old this person is?
It looks like a cosmic pediatric person. Like it's so small.
Pretty small, huh?
Yeah.
So why do you think the arches are so small?
And that was not because
Okay.
it's
Maybe the patient is a dwarf.
Dwarf, like a little tiny person? Oh, he was about this tall. No, maybe about this tall. But how old was he? Really small adult? If you count the roots, yeah, there's no first molars.
Yeah.
Yeah, so that's, you know, got 10 teeth in an arch. He's 5 years old. So, one of the things that was, you know, picture his smile. Picture what that was like.
Was it so very stressful, like, because the teeth are like reduced to stumps,
That's more than stress. That's more than stress.
like dietary habits?
It's more than dietary habits. It was mom. Okay, now that didn't mean to imply anything about what mom was doing. It's the genetics. Okay, so mom comes in and she's 27, and so you guys can probably identify with that age group. She's 27 and she's got 3 kids. She's got Paul, who's 5, and she has an older son who's 8 and an older daughter who's, I think, 10. Something like that. A 10-year-old daughter, her teeth are totally normal. Both sons had this problem. Okay. Give you a hint. The x-rays showed no evidence of any root canals.
I mean, dentinogenesis imperfecta or?
Close. It's the dentinogenesis imperfecta, yeah. So, you know, the enamel flakes off the tooth, and then dentin's soft, and then it's really easy to grind it right down to the ridge line. Okay, so how do you think he was treated in school?
Bullied because,
Yeah, bullying on steroids. Okay, yeah, he was really unhappy at school. And so, you know, we as dentists can do something about that. Now, I actually saw him and his family at first when I was a student. And I got really lucky because one of the dentists that was visiting from India at the time was extremely experienced in prosthodontics and removable prosthodontics. And he had done cases like this in India. He taught at Manipal, actually. For a while, he was the dean up at Government Dental College in Ahmedabad, Gujarat. Still can't figure out which is which.
Yeah.
The state or the city.
And the one is the state, yeah, the Gujarat is state.
Yeah. So anyway, he was an extremely experienced dentist, and so he was my mentor when I worked on this case. So he helped me do this. But what would you do? That's the trick. So the kid's miserable. He can't smile. He has no teeth. He'd never been able to smile in his entire life. He never had teeth, never ever had teeth that would allow him to smile. Now, when you're 6 weeks old and you smile for the first time, you don't have to have teeth. It's just the most beautiful thing you've ever seen in your life. But at 5 years old, the other kids were like torturing him, unduly for sure. So, the typical kind of approach that a dentist takes in this kind of a case is to, when the permanent teeth erupt, try to protect them. You've got to protect the permanent teeth when they erupt. If you can keep the enamel on because you don't have them in occlusion, then they can erupt far enough so that you can crown them, and that's your only hope. And of course, picture, implants may not be a solution. Picture mom at 27. She got full dentures at 17. Picture what her ridges were like. Picture what her ridges are going to be like when she's 37 and 47. Not much to put an implant in, huh? So that would have been the time to do those implants that go over the bone. You guys probably haven't even seen any of those kinds of things. There's names for that kind of stuff, but pretty sophisticated stuff, but very, very dramatic restoration compared to what we tend to do these days. But in any event, Paul's 5 years old, and I want to try to protect his teeth as much as possible. They became my patients in my practice after I graduated. So I saw them for a good number of years, but not enough. It takes about at least 15 years to get a kid like that to the point where he has permanent teeth that have erupted enough to make crowns on and to do it's like full mouth crowns. So anyway, the initial thing you do is you want to keep the load off the teeth, so you make him have a bite on something that's going to protect the teeth. So this is what I did with the help of Dr. Bhargava. The world's cutest dentures. They look like those things you put your keychain on or whatever. And so these are the dentures I made for him when I was a student. I made him another set when I was in my practice because, these I'd had to relieve and adjust and so forth so many times because everything was changing. You can imagine how it changes, for a few years when you're 5 years old. So I would have had to remake it and adjust it and then remake it many times to get him to the point where he's large and old enough to make crowns on. But literally, this was his first smile. Okay, I'm holding his first smile in my hands. And I cannot find it right now. I'm really looking for it, and I'm hoping I stumble across it one of these days. I have a bunch of 35 millimeter slides in boxes stored away. I really want to find, because I got a picture of him with the dentures in, smiling for the very first time in his life at the age of 5 years old. It's just absolutely wonderful. So, I will just tell you, dentistry is an amazing career. If you ever have an experience like that, take it in. Okay. So, here's Mary. I'm going to pass Mary around. Oh, you got too many things to play with already. So, here's Mary. Okay, yeah, if you both those, that's fine. And I'll give Only Steve, so you can do that, and then get another onlay over here, there's another onlay over here. Okay. So anyway, those are 3 clinical cases, and you look at the onlay preps, and they're big boxes, and there's not much left of the teeth. That's why we're doing the onlay in the first place. Okay, that's the whole point. But you can have boxes that are big enough so they compromise the strength of the tooth, and yet they can provide a lot of retention to keep the gold on the tooth that protects the tooth. Okay? So that's the cool thing.
Is it root canal treated too?
Those were not. Yeah. So don't forget that when you have a patient that's older and there's been more trauma on the tooth, and either chemical trauma or physical trauma, the pulp chambers tend to recede quite a bit, huh? Okay. I remember doing class 3s on lower incisors on an older patient, and I was doing 2 class 3s, 1 on each side, and they connected together in the middle. The decay was actually connecting together in the middle, but the pulp chamber is way down here in the root. Okay, so, yeah, and when you've got a tooth that has that kind of history, the pulp has responded to that. Okay, so as we develop the sense of doing an onlay, which we're about to do now,
I'm not going to draw it out for the typical kind of situation that you're holding in your hands. I'll draw it out for how we would do it if it were an academic exercise. We're going to do it the academic way on a typodont, and again, it's never done that way clinically because you don't need a crown. But we're going to learn how to do it that way just to develop the skills. Okay, so we've got a couple teeth, an upper and lower molars, and we'll diagram how you do an onlay for each one of these. And the first thing we're going to do is sort of figure out, okay, where would the boxes be? You know, where would they be clinically? And then we're going to put the boxes for our onlay where we would expect them clinically. Again, the patient brings the boxes in with them. Okay? And the boxes are probably centered on the contact because the decay that the boxes removed originally by some other dentist was removed and the decay was centered on the contact. So we're going to keep everything pretty much centered on the contacts. Wherever those contacts are facial-lingually, we're going to center things on there. We're going to make boxes that relate to the position of the adjacent tooth contacts. Now, these are a little bit different facial-lingually on the two sides. Again, we don't care. There's no symmetry in these teeth. There's no symmetry in these preps because they're in a mouth. Okay? Even in a typodont, there won't be any symmetry because the size of the contacts, the position of the contacts can be totally different from one side to the other. And the boxes, of course, will relate to that. So one box could be a lot bigger than the other, smaller than the other, shifted facially than the other, whatever. We don't care. Again, the preparation is going to be done in relationship to the adjacent teeth. All right, so we're going to draw some lines. Once you do the occlusal reduction, which we've already learned how to do, once you've done the occlusal reduction for the upper and lower teeth, we're going to draw these lines so that we know that we're going to center everything on the contacts facial-lingually. And then here's what I suggest. This is just an arbitrary way of sort of figuring out where the boxes should be, where their flares should be, and so forth. I'm going to divide the tooth up into 4 parts. And where the center line of the contacts gets to about 1/4 of the way across the tooth, we have a point that we can define in each of these. And from that point, we can draw lines tangent to the adjacent tooth surfaces. And those are our flare lines, just like we've done before for the 3/4 crowns. And when we make boxes, try to get a little brighter color here. When we make boxes, we're going to figure out, okay, where should the axial wall be? You've got a pretty good sense of where an axial wall is going to be. Again, clinically, it's not there. It's way inside the tooth somewhere, typically. And facial-lingually, of course, clinically, they're going to be way overextended again because we're doing a crown because there's really big boxes already there. But in this case, we're going to keep it fairly conservative. So we're going to just say, okay, for an academic exercise, we'll put the axial wall, you know, where it would be ideally. Think about a class 2 or something like that. So that's kind of what we're used to. And then we're going to make the boxes square like we do for amalgam with 90-degree exit angles. And we can bring the margins a little bit out into the facial-lingual embrasures. The flare lines are marking where we're going to flare these walls of these boxes a little bit later. And make sure we make the boxes so the corners are beyond the flare lines. So when we make the flares, we're going to flare away part of the wall, not the whole wall. Okay, so this would be about the position of the boxes. This would be where the corners are. So when we actually make the boxes, we can go gingerly in these corners. So when we make the boxes, we're going to do it very much the same way we did when we did the class 2s. Okay, drill a hole in the corner, come away from that wall, drill a hole in the corner, cut away from this wall, cut the excess off the facial lingual and gingival. 7 steps, as we've done before. Okay? Now, in this case, the only difference is that we're going to be using a different burr. We're going to be using the 170L burr, tapered fissure burr. And we're going to lean the burr a little bit extra on the facial, and we're going to lean a little bit toward the axle.
So facially and axially on the facial side, a little bit lingually and axially on the lingual side. Not too much. Some of you are already leaning more than this. So this is a couple degrees. So a couple degrees this way, a couple degrees this way, a couple degrees axial. Okay, so as we do the box and come down the corner, cut away from this side, do the box, cut away down the corner, cut away from this side, lean the burr axially and facially, axially lingually, get rid of the excess. So we'll proceed like that, gingerly, the same way we have before. So again, no new skills here. We'll proceed gingerly until we get some gingival clearance. Note that as we get the gingival clearance, the walls of the box are visible. That looks a little bit asymmetric. So we're going to keep it something like this. So I can see the facial lingual walls of the box at the same time. The way you guys are looking at it right now, you're looking down the axis, and you can see the facial lingual walls at the same time. That means they diverge occlusally, so for a cast restoration, we're good. Same thing over here. Again, lean the burr a little bit facially on the facial side, a little bit lingually on the lingual side. And I've gone gingerly enough so there's some gingival clearance. Now, of course, the cool thing is that there's probably gingival clearance to begin with, because we're doing a prep on a tooth that already has a restoration. And we removed the restoration. When they did the prep for that restoration, they went gingerly to get clearance because they had to remove the decay. And I guess we've talked about why we go gingerly as far as we do in a class 2. So we can count on there being clearance when we use the original floor of the box. Now, we might have to go deeper gingerly for reasons we'll discuss in a minute. Nonetheless, we certainly expect to get some clearance once we have removed the original restoration and just made the boxes and lean the burrs the right way. And again, clinically, we expect to already have clearance. And to type it out, we're going to have to go down and make it. Okay, so for this one up here, again, we go gingerly, we get some clearance. And note that the basic divergence facial lingually, the basic shape of the axial wall are pretty much idealized. Again, clinically, we don't have to worry about a lot of that happening. We just have to make sure that we get some divergence facial lingually, and we're good clinically. Okay, so I'm looking down here so I can see that I have some clearance gingerly. Okay, so again, we know how to do that. When we did the class 2s, we learned how to make sure we have the burr vertical. We learned how to evaluate the angulation of the burr vertically in 2 different directions so that we can see that it's vertical. And then we did the whole box that way. That gave us the most control when we did the class 2 boxes. Here we're going to lean the burr a little bit facially and axially, a little bit lingually and axially this side, a little bit facially and axially on this side. And now let's evaluate whether these preps draw at this point, because these are the retentive features. The retentive features at this point are done. We just have to finish up the prep, do some details, bevels, offsets, things like that, flares. But let's find out if these draw. We talked about what draw means. So the way you guys are looking at it, you guys are all looking down the axis of the tooth, so that's appropriate. When we evaluate draw, we always look down the axis of the tooth. How do we do that? Use the mirror in the upper arch and the lower arch. Yes, all teeth, all arches, all quadrants. Use a mirror and look down the axis. Okay, so you guys are all looking down the axis right now, except you're a little bit off. You're kind of looking from the side. But anyway, can you determine that this prep draws the way you guys are looking at it right now? I'm watching the way you guys are looking at it. Can you determine if that prep draws? This is a 3-dimensional object. Have you concluded that it draws? Okay. So have you concluded that it draws facial lingually? So when you check draw, all of you are doing it with both eyes open, I notice. Nobody closed one eye. Okay, so if you check draw with both eyes open, how do you do it so that you get the correct answer? You're checking draw between two opposing walls. Make sure those opposing walls are horizontal. You're looking down the axis. Make sure the opposing walls appear horizontal to you. And then with both eyes open, you can evaluate draw between the facial lingual walls. Remember that? Sound familiar? Okay. And again, yesterday, a couple of you were a little bit careless about checking for draw. And so we do it in every way that we can. But, you want to make sure you don't fool yourself. Okay. It's possible to fool yourself when you have both eyes open. Now, how would we check draw between the axial walls? So I want to see you guys right now checking draw between the axial walls. So I see everybody's got both eyes open. No, you closed one eye. Okay, that's good. So if you close one eye and look down the axis, what do you want to see if the axial walls drop? What are you looking for? Well, you're looking to make sure you see both walls at the same time. If you have one eye closed, you can check draw in any direction you want. Those walls, those two opposing walls could be horizontal or vertical or whatever if you have one eye. If you're only looking down the axis with one eye, that's a lot easier. Okay? So you can look down the axis with one eye and check the draw between the facial lingual and also check the draw between the axial walls. But if you have both eyes open, and we like that, I do because I like the depth perception, then if I'm going to look down the axis this way, I can check the draw between the facial and lingual, but to check the draw between the axial walls, what do I have to do? With both eyes open? Could you come up here to the board and look down the axis with both eyes open so that you can see the draw between the axial walls? You'd have to do this. Right? So again, you look so that the walls that you're checking appear horizontal to your eyes. So I'd have to turn this way so the axial walls appear horizontal, and then if I can see them both at the same time, they drop. Okay? This way, the facial lingual walls appear horizontal if I'm looking with both eyes down the axis, and I can see both of those drop. Okay, so again, be a little bit careful about evaluating draw. So we've talked about that and all the different choices. Okay, but could I have the distal box draw and the mesial box draw, and yet the prep has an undercut? Okay. Now we could have, of course, the mesial box draws and facial box draws facial lingually, but the axial walls are undercut. That's one way. But if the mesial box draws facial lingually and the distal box draws facial lingually and the axial walls are convergent, do we still have an undercut? Yes. How does that happen? Again, two retentive features, just like having two preps for a bridge. There has to be a parallel path of draw. So we might have a situation like this. Now you're looking down the axis of whether it's both eyes open or not. You cannot see this wall on the distal lingual and this wall on the mesial buccal at the same time. So there's an undercut between the boxes. So what happens is you have one box that diverges occlusally, but it's leaning this way. The other one diverges occlusally, but it's leaning this way. So the inside walls of the two are undercut. Okay? So again, you have two retentive features. They can be undercut between them. Like you have two grooves on a three-quarter crown. There can be an undercut between the grooves. Two boxes, you can have an undercut between the boxes. A PFM prep here and a PFM prep here, and a dentulous space in the middle, you can have an undercut between the two PFM preps. If one draws this way, the other draws this way, you can't make a bridge that seats this way. You have to seat like that, and you can't do that. Okay. All right, so we have to be especially careful to evaluate draw. But we've got prep. We've got two preps that draw. That's good. And as long as they're tall enough, as long as these boxes are tall enough, then they're retentive. Now, it may be that we go gingivally and we go down to where the box on the original tooth was, and we have 0.5 millimeter gingival clearance, but we might only have 2 millimeter wall heights here. So then we have to go farther gingivally to get more wall height. So the clearance gingivally is not very critical because there's 3 different things we have to pay attention to. As far as gingival extension is concerned, we have wall height, facial and lingual. We have gingival clearance. We have to have enough gingival clearance so we can make a bevel. And number 3, this is a little bit tricky. We have to have gingival clearance. So second one is gingival clearance so we can make a bevel. The third one is gingival clearance so we can get an impression. That gets kind of interesting. So we have to diagram this out. So let's say we have a proximal surface like this. We've done the occlusal reduction like this, however that goes. And we have a box that comes down gingivally like this. We want to put a bevel here. So if we have enough clearance to begin with, oops, I don't have my axial converging. Okay, so I want to have enough gingival clearance with the box so I can make the gingival bevel so the crown, the gold seats at an angle, plus good geometric fit. But in this situation right here, maybe the facial angle walls are 3 millimeters tall. I have enough gingival clearance so I can make the bevel, but I might still have to go farther gingivally. And the problem is getting the impression, because if the gingiva is way down here, and all the space underneath its gingival margin fills up, if this is the impression material, you can't get the impression material out through that little space. Okay, because when you take the impression, you actually have to get the impression tray back out of the patient's mouth. Okay? Ever heard of somebody that was taking an impression of a patient when they couldn't get the tray out of the mouth? You heard of that? That's acutely embarrassing. This kind of thing, that doesn't really fly. That's actually the only time that, the time that tends to happen the most is if you have a patient with lots of recession and you're using an impression material like my favorite, Impergum, which is a polyether material. It's very rigid. And it gets underneath all those contacts, and you're stuck there. So, yeah, you have to cut the tray apart and take it out piece by piece. It's really embarrassing. Never happened to me, but I've heard of it happening. And I can imagine what it would be like. Okay, but in a less, global sense, if we can't get the impression material out through that little space because we didn't get enough gingival clearance, then the impression material is going to tear. It's going to rip. And you might not notice it, the lab assistant might not notice it, but when the lab tech pours it up, there's going to be a defect at the margin, and obviously it won't be an adequate crown. It won't be as we should be able to do. So then we go gingivally farther so that we can put the margin down there. Now this material has enough room to go through it. It sort of deforms as it goes through, but it doesn't deform permanently. So we need to have enough gingival clearance for the impression. That's kind of a subtle point, but it can be a very important one. You're trying to get an impression of your patient, and the impression keeps tearing all the time. All right, so we know that we have to go deep gingivally. The gingival clearance is not so important. But we need to make sure we optimize each of these 3 things, especially the wall height, to make sure we can get the retention. And, however far gingivally we have to go, we have the reasons for doing that. So we're not going to be graded in school on the basis of gingival clearance. At least you shouldn't be. All right. So let's finish this lower prep. What should I do now? Let's finish it up. You know everything that we need to do, and you've done everything that we need to do.
Proximal boxes.
Connect the 2 proximal boxes. Okay, we can do that. Now, this raises a very interesting question as to why we would do that. Why do you think we should connect these boxes together? Because it looks good. Now, of course, you should think of two reasons. One reason is a little bit more obvious. I heard the word retention. In actuality, that's true, but it's really not obvious why it would help in retention at all. Because we have the facial wall of this isthmus is going to be leaning facially, and the lingual wall is going to be leaning lingually, and we're going to make those walls really short, just only maybe 0.5 to 0.75. Do the same thing up here. So even if we have to make the isthmus, we're going to do it and keep it really short. Notice I've extended into the grooves, as usual, to keep the walls uniform. So we know all about that.
But isn't it going to connect the two and keep them in place?
Well, why do we connect the two?
Is it due to the resistance, like to, because,
It will connect both of them and prevent dislodgement because it's flaring up and leveling.
Well, there's two reasons. One, probably there's an isthmus there to begin with. Okay, so in a patient, a lot of times there's an old restoration, there's a, again, these are big restorations that we're replacing. Probably there was a big isthmus, probably it was very deep. By the time we do the occlusal reduction, we still haven't gotten to the bottom of the pulpal floor. And so there's already an isthmus there. But even if that were the case, even if it weren't the case, we'd make an isthmus anyway, because the retention has to do with the gold in those two boxes. So there's gold in this box, gold in this box. And so if the walls are tall enough and so forth, we're worried that the gold in those boxes might get loose. Okay? If there's any flexibility on the occlusal surface in the gold crown between one side and the other, in one box, the gold in one box can get loose by itself. And then once it gets loose, this one gets loose and the crown falls off. If we make the gold a little more rigid between the two boxes, by making it a little thicker, it's going to be wide, much more so than we think of in terms of a class 2 isthmus. It's going to be wide and not very deep, but it's going to be enough extra gold in between those so that it's going to keep the gold from twisting between the two boxes. So both boxes, the gold in both boxes would have to get loose at the same time, which is probably like the resistance form or retention squared compared to if it were a little bit more flexible. So that's why I say it's subtle. The isthmus is to make sure that we keep the crown in place, and we're going to do that by just keeping it so it's more rigid in those areas. Okay? Some people call it a staple effect, but anyway, like I said, it's subtle but very important. So yeah, the isthmuses are something we're going to do. What's next? So that's something that we've done isthmuses before, but for totally different reasons for doing the class 2. So we know how to do them. And pay attention to the vertical angle when you're doing them. Lean a little bit facially on the facial side, a little bit lingually on the other side. Keep the wall height uniform but short. So you got the basic idea about how to do that. We're going to connect the boxes together from the corners. So if it's a big box, it's going to be a big wide isthmus. We don't care because the isthmus is deep inside the crown. Okay, it's not on the occlusal surface. It's not a class 2. Right? So what should I do now? We've already got all our retention. There's nothing to put grooves in. We've already got boxes. Remember, don't forget, if we're doing a 3/4 crown, where we reduce the lingual surface, which we've done before, if you're doing a 3/4 crown on a natural tooth in a patient's mouth, most of the time there's going to be boxes there. There's missing tooth structure. That's why we're doing the crown. Most of the time there's going to be boxes there. So typically, more often than not, when we do a 3/4 crown on the patient, we don't use grooves, we use boxes. Because they're already there. So the only difference between an onlay and a 3/4 crown is the 3/4 crown is reduced on the lingual and the onlay is not. That may be the only difference. Again, the definition of 3/4 crown is you reduce 3 of the 4 walls. That's it. That's the entire definition. It says nothing about how we get retention. Okay? So in any event, we've got all our retention, nothing, there's no axial reduction, there's no axial wall to put a groove in. That being said, you know, it may be that we reduce the lingual just halfway around. We might put a groove in the middle of the lingual and do sort of an onlay, you know, sort of a combination prep. That is unusual. Again, we look in the patient's mouth, see what the tooth needs, and figure out how to do it. We have all these different kind of ingredients, you know, different kind of techniques that we have that have certain reasons for doing them, boxes and grooves and chamfers and tapers and flares, all that kind of stuff. And we combine them together however we want to do something that's going to be the most appropriate for a particular tooth. Okay? So again, these preps are, yeah, if there's a continuum of indirect restorations, there's the full gold crown and there's the inlay. And in between, there's an infinite number of different choices. Okay? So we've got the 7/8 crown and the 3/4 crown, and over here an onlay, and then there's all these mixed things in between, depending upon, you know, you might have a tooth where not all 4 cusps are weakened, but only 2 are weakened. We might have only 1 cusp that's weakened. Maybe this is the only weak cusp. We can do an inlay that covers this cusp. Okay? So that's way over here, inlay, onlay. So again, we only need to reduce a certain amount of the tooth for specific reasons. Okay, so in this case, again, we're keeping it pretty conservative. Again, if you look at that, you know, it looks more like an MOD amalgam or composite direct restoration. Again, the cusps are not weakened at all. They're plenty strong. Don't need to do a crown, but we're just learning how to go through the basic techniques here. Now, everything else that we need to do here, we already know how to do. We've already done it before. We know why we do it. So let's do it. Tell me what to do.
Reduce the cusps.
Well, we did the occlusal reduction from the very beginning. That's already been done.
Impression.
Offset.
Say again?
Impression?
Well, no, haven't finished the prep, yeah.
Okay.
Get a little bit ahead of things.
Offset.
Offset. So where would I put the offset on this lower prep? Where would I put the offset in the lower prep?
Lingual.
I don't know. You have to tell me. You got to think about it. Where did we do it on the 3/4 crown?
We put on both.
On facial.
On the A plane.
On this.
Yeah. So we did an offset out here for the 3/4 crown. So we know about that. So we could do that. But before we did that, we finished the A plane around the corner 45 degrees on both sides. Before we did that, we had to have the proximal reduction done completely. And we haven't done it completely yet. We've done the boxes, but we haven't done. This brown line that I drew here, what did I call that line? Flare line.
Yeah.
Why? Because we're going to make a flare. So we're going to flare these facial lingual walls for exactly the same reason we did on the 3/4 crown, to get access to the margins for burnishing and to make a small angle gold so it can be burnished. Sound familiar?
Yes.
Okay. So let's go ahead and flare the walls. We need to do that so then we can bring the A plane around the corner and do the offset. Okay, so I'm going to put a flare like this. I'm looking this direction, cutting from the outside in. Now, in the 3/4 crown, I put the burr in the groove, came to the top, leaned it a little bit facially, and started cutting from the outside in. Over here, just put the burr in the corner. If the boxes draw facial lingually and axially, and put the burr in the corner, you've got the angle. The vertical angle, you've got it. So put the burr back in the corner, and then come up to the top, and then start cutting from the outside in. Over here, as we know, we cut from the inside out. Then so I'm looking this way, so I can cut from the inside out. I turn my head and I look down this way, and I can cut this flare from the inside out without changing my position much at all. And over here, I'll cut from the outside in looking in the direction I'm cutting the flare, cutting from the outside in, I've got a flare over here. So you guys have been working on making flares, so you should be able to make the flares pretty readily. The same thing up here, obviously in the upper arch we use the mirror to make it possible to make these flares. You guys love the mirror yet? Anybody love their mirror?
Trying to love it.
Trying to love it. Yeah, like a little brother, right? I think I should love him, but he's so obnoxious. But, you know, we've got the skills already to make these flares, but of course, as I've shown you many times, to make them on the upper arch, you use a mirror. You look along the wall, cut this way, look along the wall, cut this way, whatever you have to do. Make sure you're looking along that direction, then you can cut inside out or outside in. Then you got it under control.
Can't you have the whole wall flares?
Yes. Yeah, there are preps. This is what would be called a 5-wall box. So at the gingival margin, you see there's 5 different line angles.
Yeah.
And you could do it, if you flared the whole thing away and flared all the way to the corner, then you'd have just 3 walls, and that works. Whether this is more retentive or not is an open question. It looks more retentive, but the important thing is that you take the time to get the boxes just the way you want them. Okay, so adjust the box, make a nice square box like we had a minute ago. Make a nice square box, square corners, flat walls. You know, get out into the embrasures where you want. You know, really take your time to make sure you're really happy with those boxes. And then making the flares is just like this. Okay, it just takes a minute to make all the flares. If somebody sets out to try to do a 3-wall box and make the flares to the back of the axial wall from the beginning, then there's more chance to get confused about the fact that you're trying to do a good job cutting the flares. You're also trying to get the right vertical angulation and the position of those walls at the same time. So if you break it up into steps for making the box that's really square first and then just flaring off the margins, then we're good. And it just looks more retentive. Again, whether it is or not is debatable. Make sure that the flares go all the way down to the gingival floor. Okay, because ultimately we're going to put a gingival bevel on there. We want it to join the bottom of the flares. And it can't join the bottom of the flares if the flares don't go to the bottom. Okay, so we've got boxes, we've got an isthmus, we've got flares. What do I do now? Let's finish the lower one. We talked all about how we design preps so that they work well.
Yeah, bevel on the digital floor.
Okay, we could bevel the gingival now. Yep. Before we do that, we'll probably bevel the axial pulpal line angle. Then we can bevel the gingival floor. And so we'll just you can use the same burr. A lot of times there's so much clearance gingivally that we could actually even use like a 170L or something and make that bevel. I often do. So bevel the axial pulpal line angle a little bit, bevel the gingival floor significantly. And how do we make that gingival bevel? We know exactly how to do that. You take your burr, put it against the wall, cut gingivally right there, just like you're doing it on a class 2 gingival bevel. Put the burr against the face wall, cut gingivally right there, cut into the gingival margin, then cut toward the middle. Same thing over on this side. Then we get a nice smooth continuous. So we know how to make that smooth continuous bevel join the bottom of the facial angle walls. Most of you did a decent job on that yesterday. Okay, what should I do now?
Offset
Offset. Where should I do the offset?
on the apron.
On the A-plane. Okay. Before I do that, I want to finish the A-plane around the corner at a 45-degree angle. Now I can do that because I've opened up this proximal area. And then I can bring the offset around like this, just like we've done before. Nothing different. You can use the 171 burr, come around there just like you've done before. And of course, so if I'm making the offset like this, then when the offset gets to the flare, there's a sharp corner, so make sure you round over the corner at the top. So bring the bevel. So remember we have a bevel here that we create between the offset and the margin. There's a bevel. Make sure that bevel comes around the corner into the top of the flare smoothly. just like the bevel gingerly comes into the bottom of the flare smoothly. So we already have some experience making smooth, continuous margins. Okay, are we ready to finish this prep? What do I do now? Got any ideas?
Foundation of any short cusp.
Yeah, there aren't any sharp cusps right now. There's this cusp here. It's not, if we had an axial wall like this, and if that were internally, that would be an issue. But it's not necessarily sharp in terms of, keeping us from being able to make a good crown that would seat. But don't forget, we want to make sure that the gold at all margins has a small angle for burnishing, right? That was one of the requirements that we talked about last Friday. So how about we bevel the lingual cusp? And make a significant bevel, so we have just a thin layer of gold right over there, so it's really easy to burnish. And of course, we make sure that that lingual bevel joins the top of the flares on both sides. So a smooth, continuous margin right around there. Okay, so that prep is finished.
Does the bevel have the same function as an offset
No,
in terms of burnishing?
no, the offset doesn't have a function at all in terms of burnishing. The offset is only to strengthen the gold in this area so that the gold isn't going to deform. Remember, the gold's hanging out on the outside of a functional cusp. So we're kind of worried about it deforming over here, so we strengthen the gold by making it thicker near the margin.
So you're not worried on the lingual side?
In terms of the strength,
Yeah.
right here, you might think so. On the 3/4 crown, remember the 3/4 crown on the facial? Very similar to the lingual of the onlay. And we put an offset over there, didn't we?
Mm-hmm.
So you think we should do an offset over here? We might. But again, the purpose of the offset is to make the gold more rigid near the margin. The purpose of the isthmus is to make the gold more rigid between the two boxes. The offset, or the isthmus, is coming out onto the C-plane here. So it already has a function of making the gold more rigid in that whole area, and it might do the job. If we think that the isthmus is too far from that lingual cusp, sure, why not put an offset in? We could certainly do that. Again, as long as we know why we're doing it, and then we think about if it's really necessary or not. In this case, it's probably not necessary. Most people think that it's not necessary, but if you have two boxes that are shifted out facially because of the position of the proximal contacts, the lingual cusp is way over here, and the isthmus is far from those lingual cusps, then definitely put an offset in just like you did on the maxillary 3/4 crown.
Yeah.
Great. All right, good question. Let's finish the top one, the maxillary prep. What should I do now? I'm ready. Tell me what to do.
Bevel the gingival floor.
Bevel the gingival floor. Okay, it's Mr. Bevel over there. Okay, what should I do now?
Angle.
Okay, bevel the occipupal line angle, okay. And now?
A-plane offset.
Angle the cusp.
A-plane offset. You think I should do an offset up here? The isthmus makes it so that, again, most people believe that with the isthmus there, which is increasing the rigidity in that whole area, that we don't need an offset there. So what should I do?
On the C-plane offset on the C-plane.
Offset the C-plane. Okay, because this area is exactly the same as the facial margin down here. Exactly the same as the lingual margin up here. No difference whatsoever, and so we do exactly the same to take care of that. Finish the C-plane around the corner at a 45-degree angle before we make the offset.
On the 3/4 crown, why didn't we offset the upper?
Yeah. It's on the
Lingual
C-plane.
You want to be shaped.
What's the weaknesses in those areas and how we might strengthen the gold in those areas. Okay, so let's finish this upper one. What should I do now? Let's finish it up.
Bevel
Bevel where?
on the lingual cut.
On the apron?
How about the facial cusp bridge? Okay. This is what you mean, I think, right?
Yeah.
So a little horizontal bevel, just like we did for the 3/4 crown, a little horizontal bevel all the way along here. For the 3/4 crown, of course, we also put an offset near that bevel, but the bevel had a separate purpose. So you want a little bit of gold coming over that facial cusp bridge. And again, so the gold comes just over the top of that cusp bridge like this. So again, it's highly burnishable, and I like the fact that it's just kind of over that ridge a little bit to, again, hold everything together a little bit better.
Do we have to cover the facial cusps, or is just if it's weak?
It's a good idea. It's a good idea. But again, it's just a small little micro bevel just to get over that cusp. And again, if the gold in that area is contoured the way it should be, nobody ever sees it. And again, look on the web-eds.org website, and look at the pictures in Mary, and you can see some gold coming over here. When you're looking straight at it like this, you can see some gold coming over those facial cusp bridges. That's, you know, maybe a little bit more than I would have wanted. But then you look this way, even with the lips pulled back, if you're looking this way, it's really hard to see any gold there because the light doesn't tend to reflect back at you.
I mean, would it be okay if the gold stops at the isthmus part?
Oh, it's possible. It kind of depends. It depends on the occlusion. So in fact, I'm not sure if I'm showing it anywhere yet. I have basically an inlay onlay on an upper premolar prep. I happen to type it on at home now. And you might see it go by as I'm showing how to evaluate class 2s or ground preps or whatever. So I'm floating around in one of those type-it-ons. But it's a pretty cool prep. So I'm only reducing, say, half of the A plane. So on a premolar, so if you do a crown on this premolar, we might do a prep that covers this area, but on the mesial buccal, we don't prepare that. Now, a lot of times, if there's no occlusion in this area, and a lot of times there isn't, depends on the patient. If the centric occlusal contacts are over here on the distal side, we can reduce that, put a millimeter of gold over there. We don't necessarily have to reduce this. Okay? So that whole mesial buccal cusp can be totally untouched. And of course, the aesthetics are fabulous. But again, it depends on the patient. You know, if we have to touch it, then we come to the cusp bridge like this, put a little bevel over there, and again, we can develop the contours of the gold so that no gold is seen. But, you know, that's the kind of prep that can be done. I think in the one that I illustrated, everything's held in with basically an inlay prep. It's an inlay that doesn't even cover the lingual cusp, I think. Maybe it does. There's all kinds of different choices. I think it does cover the functional cusp, but it's an onlay that doesn't cover the entire A-plane.
Does this part have like some rules, like 2 millimeter depth or thickness, so that we don't reduce it, or?
Well, first of all,
More than that, then we cover it?
first of all, we can't have an occlusal contact here.
Okay.
But second of all, we have to have the gold a millimeter thick all the way along these edges here. So you're going to make the prep, you're going to reduce it and make sure there's enough thickness of gold all the way to these margins right here. So yeah, a lot of the things that we already understand about gold would allow us to kind of figure out how that might work. But it's a, you know, it's not an unusual preparation to have been done some decades ago. But on the other hand, now it's a labor of love. You know, dentists that are active members in the Dick Tucker Study Club, for example, might very well do, well, that 7/8 crown I showed you in the premolar, that would not be that unusual in a Dick Tucker Study Club course or program, workshop. And something like this wouldn't be all that unusual either. But, you know, it'd be the dentists that are in there go to join those groups so that they can learn how to do, some pretty sophisticated dentistry. And the guys that are mentoring those groups, they've been around for a while, so they know how to make some interesting choices and, really do something that's going to be the best long-term benefit for their patients. But sometimes it is a labor of love. Okay? So if you love dentistry enough to do absolutely the best thing that you can for each patient, then there's a lot of choices that you have to make. And there's a lot of people that you can go to learn, how to do some things that are basically more fun than just doing routine stuff over and over and over. Again, if you have one solution that you do to every problem, then it's not going to work. It's not going to be the appropriate solution for most problems, and it's boring. Okay, you're just doing the same thing all day long every day. So it's interesting to actually solve some problems, to come up with some interesting designs, and to figure out something that is really going to be particularly useful. Okay, so we've got an idea about this lower prep right here. First of all, any questions as far as the gold onlay is concerned? So I'm going to talk a little bit about porcelain. So we know a lot about porcelain already, but if we picture a tooth that had boxes originally, and it needs a crown, and we're going to do a crown, and we want to do porcelain because we have a CAD/CAM machine, then we have to alter this prep quite a bit, because we don't want to have 10 or 12 degrees divergence. It's a little bit too tight for porcelain, so we're going to angle it outward, get a lot more divergence. We can't have small angles of porcelain at the margin because it'll just chip away, so we'll have good bulk of porcelain at the margin. So we're going to redesign this prep. Obviously we're not going to make flares, because flares are so we can burnish margins. We can't burnish porcelain for sure. So we're going to make sure that the boxes have exit angles that are 90 degrees, because we need the bulk of the porcelain, and that we don't have too much, don't have too tight a taper, that we have everything divergent a lot. And make sure we don't have any sharp or well-defined internal line angles or external line angles. So we know the requirements basically for porcelain. So if I were to do a porcelain crown on this lower tooth, I would do more occlusal reduction, wouldn't I? So I'd reduce more occlusally. And I would make sure that I got a good bulk of porcelain at the margin, so I might come down like this. I might have the margin in the same place, but I'm going to come down like that. So there's a 90-degree bulk of porcelain at that margin. I'm probably going to come over the lingual cusp and come down here and make a 90-degree angle over there. I will diverge the walls facial angle even more. And my gingival floor will not have a bevel, but it'll be sloped gingivally. So remember when we did the full ceramic, we had a horizontal shoulder and we angled it gingivally and made a rounded internal line angle. We're going to do that same kind of thing on the boxes here. We're going to drop the whole margin gingivally. Okay, so this porcelain onlay is what I had done in my mouth over here on tooth number 30. I had it done on 2 teeth. We'll talk about 30 mostly. So I had the porcelain onlay prep done, and the crown was seated by CAD/CAM. As I said, it fell off the next week. He cut another one with the milling machine and then cemented that more carefully. Stayed on for, I think, 5 or 6 years. It didn't fall off, but there was an open margin in the distal gingival marginal area. In that open margin, so when I saw the radiograph, I saw, a year or so after I had this porcelain onlay done, the radiograph looked like this. So here's the tooth, here's the porcelain, and then in between there's this area here, which was the cement trying to get to the surface. It couldn't quite fill the gap. And that radiographically looked like it was about 0.5 millimeter. It's a pretty significant open margin. And the cement didn't quite fill that. If it had, it could again leach out over a period of time and leave a defect there. So I had a defect there, and that defect eventually started to get decayed. So I had a decayed area, something like this. Okay, so my new dentist discovered that decayed area. And so he suggested that we do a new crown. It's hard for him to patch that area back in. Yeah, I gave him the benefit of the doubt on that one. A lot of times we can, depending upon how far gingival margins are. A lot of times on a crown, we can just patch the margin up. And maybe he could have. Again, if you have patients that have enough recession, so the margins are far enough gingivally, and then that can give you some access to that area. If you have a patient that has root decay, which is decay at the CEJ, so if you have a patient that has root decay, you can generally restore it by taking a round burr in from the sides. You have access to that area, even right in the middle of the proximal area. You have access to that margin. You can kind of prep right in there and just fill it with amalgam if you wanted to. So there's a variety of different choices as far as getting access to root decay. Well, same thing here with this gingival margin, but okay. So we decided, and I was happy to get the porcelain out anyway. I really wanted to get the porcelain out. So I said, look, just, you've already got a prep that's leaning like this, that's divergent like this, facial angle. So if I wanted a gold onlay, I would have preferred a gold onlay from the beginning, but if I wanted him to do a gold onlay, he would have had to upright these walls, and then everything would have gotten a lot bigger. And, I didn't think that maybe, with some dentists that I've known in my life, I'd say, yeah, give it a try. With him, I just sort of thought, okay, I'll make it easy. Okay. So I said, just do a gold crown right over the top of the porcelain onlay. Okay. So it's porcelain covering the occlusal surface, porcelain into these boxes, and now he's going to do a gold crown, just cutting it as if it's an intact tooth. So the porcelain's been on there for 5 or 6 years, so it's cemented to the tooth, it seems, pretty well. So just do the occlusal reduction for gold, do the axe reduction all the way around, take an impression with crown bait, and then the porcelain will basically work like a buildup. Okay? All right, so that's what we planned, and he did the occlusal reduction. So when he was doing his crown prep for the gold, of course he didn't reduce as much, so it's going to be porcelain on the occlusal surface. And when he does the proximal reduction from the facial, so he's got the facial. Now we have a gold crown preparation that we're doing, so it's facial reduction, chamfer, secondary plane, lingual reduction like this. And of course the margin comes through gingivally. He's going to dip the margin underneath the decayed area there, as he's coming through the proximal area. And of course he's just making a chamfer on the proximal surface, so there's going to be porcelain at the axial wall in the box. He's not going into the box at all, so it's going to be porcelain in the box, porcelain on the occlusal. Okay, but it's basically acting like the buildup, in effect. Okay, get the picture where we are? Okay, so he does the gold crown prep. There's porcelain on the occlusal, there's porcelain in the box. He takes an impression, he's ready to send it to the lab. He has the assistant making the provisional. So while the assistant's making the provisional, she all of a sudden goes, uh-oh. Okay, and as a patient, just a reminder, the last thing in the world the patient wants to hear is the word oh. Okay, so don't ever say oh. Tell your assistants, don't say oh. Don't say whoops. So anyway, she said, all the porcelain just fell out. That was interesting. She said, all the porcelain just fell out. So I went, oh, that is interesting. So that told me something very specific. I learned something very important from that experience in my own mouth. So what did you just learn? What do you conclude from the information that you have?
Want to say oh?
I love it. Okay, well, that actually wasn't a conclusion, that was what I told you. That was the easy part. I'm not gonna necessarily give you the answer to this other question, so. So again, picture yourself in the chair, you've got a porcelain onlay, you know what a porcelain onlay looks like, how it's prepared, where the margins are, stuff like that. You know about adhesion, you know that it stayed in for 5 or 6 years, you know that he did a full crown over the top of it, you know how full crowns are done in reducing the proximal and the facial lingual surfaces and the occlusal reduction. You know there's porcelain left after he did the full crown reduction, but the porcelain fell out. Okay, what are the implications? Can you work through it step by step?
Because we use a lot of porcelain because of tooth cutting. And there is no retention of a porcelain. There is kind of porcelain, is kind of a tooth structure, so no tooth structure is left because tooth have an intact compact surface, but for the porcelain it's become loose because of the reduction.
Okay, so there are a couple points that you're making. I have to sort of separate them out a little bit. So, you know, one conclusion you could make is that just the cutting on the porcelain somehow loosened it from the tooth, whether it was heat or something like that. That's a possibility. But one of the things you said was that the porcelain wasn't bonded to the tooth. I mean, it fell out, so clearly it wasn't bonded to the tooth. Could there be another explanation that might be a better one?
When we're making the crown on the preparation, we're cutting off the margin. That means that 90-degree angle and porcelain has strength to and retention.
That's for the original onlay.
Yeah, through those margins. So when we cut that off, it just weakens it, and that possibly
Well,
make the porcelain.
okay, so picture the porcelain onlay preparation, the way it's done as an onlay, and then picture how much of the porcelain is left and where it is once you've prepped all the way around the tooth with the gold crown prep. So what's the biggest difference between where the porcelain is with the onlay and where the porcelain is as it's been mostly cut away? Where was it cut away? Where was the porcelain cut away when the gold crown prep was done?
They also, generally they make chamfer.
Yes, gold crown.
Yeah, and.
That's why there's still porcelain at the axial wall in the box. It's not porcelain at the margin anymore. It's only at
Especially
the
on
axial wall.
occlusal.
Say again?
Occlusal, if we cut the occlusal through porcelain.
Okay, so there's less porcelain at the occlusal, but what's the really critical thing here? There's less porcelain in an area that's probably more retentive adhesively, and this experience proves that it's more retentive adhesively in these particular areas. Huh?
On the axial walls, on the sides,
The axial walls, we don't expect that to necessarily be the most retentive part for an onlay, as far as adhesion is concerned. If you had to decide, if you're submitting porcelain to tooth structure,
We are not able to.
what tooth structure do you think would be likely to get the most adhesion to?
No?
Dentin? Well, maybe you'll think that, and then this experience will change your mind, right? Because we have two different tooth structures that we're thinking about, enamel and dentin, right? And so we have an onlay prep, a porcelain onlay prep. So where's the enamel on the porcelain onlay prep?
Margins.
At all the margins, every margin is in enamel, right? What happened to all the enamel of those margins when he did the crown prep, the gold crown prep over the top of it? All of it went away. So for the gold crown prep, there's no porcelain touching any enamel because there is no enamel. There was before, now there's none. So the most likely thing is that the porcelain that was left after the gold crown prep fell off because it was never bonded to dentin. It was only bonded to enamel. And we expect that we get an easier bond to enamel than to dentin. We talked about how to get a good bond to dentin, but apparently that wasn't done in this case. And as I said, when he cemented that porcelain onlay at the beginning, it fell off in a week. And he used the same cementation method the second time, but apparently he was less careless. And so it stayed on for a lot longer period of time, but it never was bonded to dentin. It should have been. It could have been. We have the technology, as you know, to bond porcelain to dentin, but it likely never was. It was only bonded to the enamel. That's what was keeping it on. So you might want to think, okay, if you're doing a CAD-CAM crown or an all-ceramic crown, you might prefer to do an onlay because there's enamel at all the margins and it's probably not going to fall off as readily. Whereas if you do a full crown of porcelain or ceramic, then you have no enamel to bond to and you have to make sure that you're bonding to dentin. And a lot of dentists don't, so again, there's a loss. Okay? So again, you know, when you get experience in your own mouth, it can be very educational. You can learn a lot about how things work. And again, based on the discussions we've had, that's a pretty interesting piece of information. So if I had a CAD-CAM machine and I was doing porcelain crowns on people, I would try to do a porcelain onlay for everything. And the chances of it falling off are much less. All right, so there are the take-home lessons. What are we going to do today? We're going to do number 3. We're going to do an academic, conservative onlay preparation that makes no sense. Okay, again, we never would do that clinically because if we could do it clinically, it doesn't need a crown, as we've discussed. But we're going to try to keep the boxes small and conservative and develop, you know, keep developing the same skills that we've been working on, making flares and isthmuses and offsets and bevels and that kind of thing. So you had a number 3 on your exam yesterday. So to the extent that we can, we're going to fix that and make it better. If you had ski jumps, you're going to get rid of them. If you're over tapered, you're going to make the appropriate changes to make sure that it is retained well. We're going to change the preparation so it's going to be more successful clinically. We'll work on that together. We're just on number 3 for right now. We'll work on that together, and then once we finish that, which won't take too long, we're going to take it out and replace number 3 and do another occlusal reduction on another number 3, as if you're doing a 3/4 crown. Same kind of occlusal reduction we did before for a 3/4 crown, save that facial cusp bridge. And then we'll use that occlusal reduction to do an onlay a little bit later. Once everybody gets the occlusal reduction done on their number 3, and they're ready to do the onlay, then I'll demonstrate the onlay on my typodont, and then everybody can do an onlay. And then after that, I'll demonstrate how to take the gold onlay preparation that I did on my typodont and modify it so it makes a ceramic onlay preparation. Then we understand the difference between the two. And then we have reached the end of our road.
Can we use seminar for more geo preparation that we made on number 3 to modify the occlusion?
Yeah, if you have an old prep that's got some boxes on it already, something like that, I don't care how big they are, yeah, you're free to use that. Yeah, just let's finish the full crown that we did yesterday on number 3, and once we finish that together, then you can put whatever other number 3 you want in there, and then we can do an onlay preparation on that. Okay? We need to figure out how to get a good group photo. I'd love to connect our group photo. This is such a fun group. I'd love to connect that to all these recordings that we're doing. That would be fun. Maybe you don't want to. Well, you know, again, the enthusiasm that you guys have is what makes my life fun. Okay, my life is pleasurable because of you guys. Okay, and in fact, at one point in my life, I had 3 different jobs. I had my private practice. I was teaching dentistry at the dental school, and I was teaching dentistry just like this off campus to international dentists. And at some point I had to decide, okay, I'm working too hard. You know, there's just, 100 hours a week is just a little too rough. So the first thing I did is I closed my practice. Okay, or I moved away from my practice. And the second thing that I had to decide was, okay, do I work in the dental school working with traditional four-year dental students, or work with international students? And that was the easiest decision I ever made in my life. Okay? Because as a teacher, you know, the craving is to work with people that are just really passionate about learning. Okay? And so that's why I enjoy so much doing what I do now, is because every one of my students is passionate about learning. And I didn't find that to always be the case in the four-year dental school curriculum. Okay? Hopefully that's changed a little bit back then. You know, if you just did what the school told you and didn't do any extra, you could still graduate and be confident about doing good dentistry. These days, when you graduate, you know, if you just haven't done enough haven't got enough clinical experience in the school, then you're not going to graduate in a confident way. And so you have to work hard to graduate in a way that's going to make you confident about doing good clinical dentistry and walking right into a practice. So that really intense effort is something that is a lot more characteristic of my international students, which is why I love you guys so much. Okay, so anyway, that's kind of where we've gone. So we've covered a lot since you've been here, and keep those lessons evolving within you, and keep them growing. You know, don't throw the workbook away. Don't put it away. Keep it right with you, and you know, continue keeping your mind active in these areas. And again, between the visualization exercises and the worksheets, you should be able to get to a dental school and blow them away. All right? So again, when you get to a dental school and you're working in a lab doing some preps like this, the other students are going to be watching you and they're going to go, wow, how'd you do that? That's amazing. They didn't tell us how we might do it that efficiently. And then you will say the magic words. Would you like me to show you? Or they will ask you, could you show me how you did that? And you're going to say the most magic word ever.
Amen.
Yes. Yes is a great word. In fact, the only reason I'm standing in front of you today is because at one point in my life I said yes. I just graduated from school. I just got my license. I was teaching at the university. And one of the faculty members, who was a periodontist, she had not been licensed in the United States. She was trained in the U.S. She did periodontics in the UK for a long period of time. So she came back and said she can teach without a license, so she can't practice. So she wanted to get her license, so she asked me if I would help her. And that's the first student that I ever had to help get a license. And so I said yes. And so we got together in the afternoons on a Sunday, and we would do some practice preps, mount some extracted teeth. She had to do a crown and a class 2, and she hadn't done any of those in 15 years. So once we started working on that, she ran into there's a written part of the exam, and she was studying in the library, ran into some other students that were preparing for the same exam or other candidates for the exam. And they asked her, do you know anybody that can help us with the practical part of the exam? She says, I do. And then all of a sudden I had 4 people every Sunday afternoon working together. And then that exam went by, everybody did well. And then the next thing I knew, I had 8 people in the next class. And then one of them had a wife who was preparing for the California bench exam, which was like we're doing here on typodonts instead of on patients. And so they asked if I would help her, and then I said, yes. I said, if she can find 3 other people, and I'll set up my garage at my house with a bench, and I'll get a compressor, and we'll set it up so I can work with you guys in the garage. And so that was the beginning of, after that, when I'm working with the students for the clinical exam at the university, I had usually 2 groups of 15 after that for every exam. So I had 30 students for every exam, and then when I was working in my garage, I would usually have 10 international students in my garage every weekend. It was amazing. But, and it didn't have heat in the winter, it didn't have air conditioning in the summer. It was a pretty miserable place to be. One day, we even had a skunk walk in. So he's walking, his little tail going like this. So everybody's back up against the garage door like that. But, no matter what it takes, knowledge is the key thing. And so I'm hoping I got you guys on a good start for creating the path of knowledge that will take you the rest of your life.
Thank you.
All right, so take a little break. Then I'll come around and help you with number 3. And then after everybody's got another number 3 ready to do an onlay prep, I'll show you how to do the onlay prep. I'll do that demonstration, and you guys can get started there. In the meanwhile, I've got some letters to write.
Thank you.